Good evening, everyone. Thank you for joining us tonight. Welcome to the Evexia webinar series. Our topic for tonight's special webinar is hydrogen methane breath testing for common GI issues in today's healthcare environment. My name is Joanne Iverson. I am the Director of Client Relations for Evexia Diagnostics and will be your host for this evening. Today, I have the distinct pleasure of being joined by an exciting guest, Dr. Martin Hahn, who will be our presenter for this webinar. Martin was born and raised in Germany. He is a physician with over 30 years of experience in clinical practice, internal medicine, gastroenterology, as well as significant experience in laboratory and clinical research. He has published numerous papers and has participated in multiple clinical trials involving infectious diseases, metabolic and liver disorders, diagnostic modalities, and medical devices. He co-founded and became senior partner of North Shore Gastroenterology, a large single specialty practice north of Boston, where he provided specialized gastroenterology services for 16 years. After leaving direct patient care in 2017, he has been involved in healthcare consulting, investments, and philanthropy as the president of the Manchester Hahn Family LLC. He also serves on the Town Board of Health in his place of residence. In the winter of 2020-2021, he and Bill Stone started AllClear Healthcare. In addition to Dr. Hahn, Bill Stone, the founder and CEO of AllClear Healthcare, will be joining the conversation. AllClear Healthcare is an innovative, personalized health diagnostics organization focused on helping practitioners meet unmet needs in healthcare with the combination of rapid, accurate, and affordable diagnostic solutions. This company's mission is to help reduce the cost of healthcare while helping practitioners and patients accelerate the time to better health. As always, joining Dr. Hahn and Bill tonight will be Dr. Wayne Sedano, our Director of Clinical Support and Education at Evexia Diagnostics. Additionally, Dr. Sedano is the Director of Integrative Medicine Education for the College of Integrative Medicine and lectures and teaches internationally. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your questions in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within a day or two. In addition, you have the ability to download the slides to follow along with Dr. Hahn's presentation by clicking the download button in the handout section of the webinar's interface. Without further delay, I will now turn this webinar first over to Bill Stone for a few minutes, and then he'll turn that over to Dr. Hahn, who will start this webinar. Bill?
Thank you, Joanne, and thank you all for joining us today. I just want to say that we here at AllClear are thrilled to be partnering with and supporting the Evexia team and all of you. And that's really what I wanted to get across. And we, as Joanne said, we have a mission now. It's to reduce the cost of healthcare and help practitioners and patients accelerate the time to better health. We were born at the time when COVID kicked in. Martin and I jumped in together. Thank goodness for having Martin by my side. I am not a doctor. I have two grandparents who are doctors, and learned very quickly how little I knew and how humble I needed to be in this space. So without further ado, I'll let you move forward with the presentation. Martin, thank you for helping us through this.
Oh, thank you very much, Joanne and Bill and everyone. Thank you very much, Evexia, for organizing this and inviting us to do this. And thank you to all the participants for spending your evening with us. I'm thrilled to be here. I'd love to talk to you about the relevance of hydrogen and methane breath testing for the GI-related disorders that I've dealt with for 25 plus years, with particular emphasis on why it is needed on a broader basis in today's healthcare environment. As Bill mentioned and Joanne mentioned, we're a CLIA certified lab that is based in Massachusetts. And we do FDA approved and CLIA waived testing for a variety of illnesses. As such, we're obliged to follow all manufacturers' instructions to the T and cannot deviate from those protocols at all. All our technicians are trained on the analyzers before they're starting to test. And we test our analyzers regularly for accuracy, and with every new lot of test reagents. We also participate in internal and external quality controls. All the breath tests are reviewed by me. As Joanne mentioned, I'm a gastroenterologist and have had a lot of experience over the years. We strive to offer affordable, accurate, and rapid testing accessible to everyone without delays. Here the agenda for today's webinar. We are going to discuss the principles of breath testing. We will talk about the most common indications and conditions for which these tests are useful. I will then talk about what to look for in a good quality test and how it should be done correctly. I'll then briefly discuss the interpretation of breath tests to illustrate that that takes quite a bit of expertise, and we'll then get into which tests to choose for specific patients or customers. Without further ado, sugar molecules are usually metabolized in the small intestine. With that I mean glucose gets absorbed directly, as does fructose. Both are single molecule carbohydrates, so-called monosaccharides. Two sugar molecules, so disaccharides like sucrose and lactose, get split by enzymes that are present in the small bowel lining. And the resulting single sugar molecules get then absorbed in the small intestine. Any abnormalities in these processes result in sugars getting metabolized by bacteria, either in the small intestine, in small intestinal bacterial overgrowth or SIBO, or in the colon if absorption is not possible in the small intestine. This results in abnormally high production of hydrogen, methane, and sometimes hydrogen sulfide. Absorption of these gases into the bloodstream leads to them getting exhaled through the lung. These gases can then be measured in the breath samples utilizing a gas chromatograph, always gives me trouble, which we utilize to do breath testing for abnormal carbohydrate metabolism. This generally requires collection of breath samples, first at baseline and then at regular intervals after a challenge dose of a specific sugar. And we then plot the gas measurements over 3 hours to identify abnormal increases in the gas concentration. Here's a picture of a typical gas chromatography analyzer and the vacuum tube breath sampling kit. This is actually the kit we utilize. In the digestive tract, bacteria are normally limited to the colon. Most of the bacteria contained in food are killed by the acidity of the stomach, so the small intestine usually has very few bacteria in it. In some conditions, called small intestinal bacterial overgrowth or SIBO, bacteria exist in high concentrations in the small intestine. Their presence in that area can interfere with the absorption of sugars, some vitamins, and other essential nutrients, causing often vague and chronic GI symptoms, so it is important to diagnose these conditions. If the small bowel contains significant bacteria, the ingestion of specific sugar substrates like glucose or lactulose leads to increased gas production of hydrogen or methane or hydrogen sulfide or all three of them via fermentation of the sugar by the bacteria in the small intestine. In other disorders like lactose intolerance, a different mechanism leads to the increased production of these gases. If a sugar like lactose, as I mentioned, a two-sugar molecule, is not split by the lactase enzyme and then not absorbed and metabolized properly in the small intestine, it passes into the large intestine, the colon, where it is exposed to the colonic bacteria. This again leads to fermentation and an increase in gas production. Individuals who lack the lactase enzyme partially or completely will have such abnormal breath tests after a lactose challenge. The same occurs in people who have fructose malabsorption after they ingest a significant amount of fructose. And I'll talk about these in detail later. Using such specific sugar substrates, makes it possible to then identify the various disorders of carbohydrate metabolism and small intestinal bacterial overgrowth, or SIBO, with such simple breath tests. Here's a nice schematic that illustrates the principles I just talked about. The substrates get ingested. With SIBO, for example, the glucose gets fermented in the small intestine, which leads to a positive breath test. Lactose usually passes into the cecum and can be used to measure orocecal transit time. But if there is small intestinal bacterial overgrowth, the lactulose gets fermented here as well and can lead to increased hydrogen and methane production and increases in those in the breath samples. Lactose or fructose reach the colon. Lactose if there's no enzymatic hydrolysis of that sugar, and fructose if the absorptive capacity of the small intestine is too small, so excess fructose and lactose would get into the colon, get fermented, and lead to hydrogen and methane production, which is then measured in the exhaled breath samples. Here are the different tests we can do and the substrate sugars utilized for each. Lactulose is used in diabetics for SIBO testing to avoid high blood sugar problems in such patients, but it is much more problematic in the interpretation and less accurate than using glucose for SIBO testing. We use standardized substrate amounts, except for children or very small adults, where we would use a weight-based dosing regimen. The reason for that is that the intestinal length and the absorptive capacity does not usually differ that much from person to person, regardless of size or weight. Different protocols for breath testing exist in the literature. That adds to the problem in interpreting test results and interpreting research studies. For all these disorders, the symptoms are very similar because the mechanism for the development of the symptoms is the same as I just mentioned in the principles for the breath testing. The sugars get fermented rather than absorbed properly and cause bloating, loose stools, nausea, cramping, and other kind of general and very common GI symptoms. These symptoms are actually very common. When 50 clinical studies were pooled in a meta-analysis, more than 1/3 of the patients that carried a diagnosis of IBS tested positive for SIBO, and IBS patients were nearly 5 times more likely to test positive for SIBO compared to healthy people. There are lots of studies that show that a good number of presumed IBS patients may also really have lactose intolerance or other disorders of carbohydrate metabolism. This translates into millions of people suffering from either SIBO or lactose intolerance or other such disorders, even though they may have been told they just have IBS. IBS, or irritable bowel syndrome, as you know, is a very common diagnosis, but it is really a diagnosis of exclusion without specific tests for it or to prove its presence. One has to undergo extensive testing to rule out all kinds of disorders with similar symptoms, and in reality, this does not happen all the time. It is easy for a provider to rule out some major issues and then label the patient with an IBS diagnosis, recommend some medications and supplements to treat the symptoms. However, it would be desirable for a lot of such patients to rule out these common disorders of carbohydrate metabolism, since most of them can be improved dramatically with the right diet, specific enzyme supplementation, other supplements, or more specific treatments. Another issue is that other significant illnesses like Crohn's disease or ulcerative colitis can have symptoms that are caused by these disorders of carbohydrate metabolism. And therefore, these symptoms can be treated as such, improving those patients' well-being. A meta-analysis from 2019 concluded that the incidence of SIBO was 9.5 times higher in people with Crohn's disease and ulcerative colitis compared to controls, and even higher when the patient had a history of intestinal surgery. This obviously leads many experts to believe that SIBO and other disorders of carbohydrate metabolism are very common, and affect a significant enough percentage of the population to make it worthwhile to roll out accessible testing to everyone. Let's talk about some underlying causes for these disorders. Ethnic background is an important consideration. Lactose intolerance is common in Asians, Middle Eastern countries, Jewish and Italian heritage. Celiac disease, which is common in Scandinavian, German, Italian, and Celtic heritage, leads to damage in the small intestinal mucosa and loss of the sugar-splitting enzymes. Therefore, it is commonly associated with lactose intolerance. In fact, in such patients, a strict gluten-free diet can improve and restore the small intestinal mucosa and improve the lactose intolerance. After GI infections or antibiotic therapy, temporary enzyme deficiencies can occur that lead to such symptoms. Reduced gastric acid in older age from medications or from surgery can lead to bacterial overgrowth of the small intestine. A common theme in many of the other underlying causes listed on the right side of this slide is the association with motility problems in the bowel, leading to stasis or stagnation of the small bowel contents, and therefore opportunities for abnormal bacterial overgrowth to occur. For example, in inflammatory bowel disease, scarring will impair the motility. Scleroderma will do the same thing. In diverticulosis or after bowel surgery, there are things like a blind loop or stagnant areas in the bowel that can develop overgrowth. Let's talk about some of the more specific disorders in more detail. SIBO, I already alluded to that it is very common. Maybe 1/3 of patients with a diagnostic label of IBS actually may suffer predominantly from SIBO. In some studies, there's one from 2013, the prevalence of SIBO in up to 20% of the overall population is suspected. And they thought that even more commonly would be present in underlying disorders of the GI tract. The harsh acid environment of the stomach kills most bacteria that are ingested. I already mentioned that there's usually a very low bacterial count in the small intestine. However, in achlorhydria, the lack of acid production in the stomach, bacteria may pass into the small intestine and colonize there. This can happen during aging with medications such as anti-reflux or anti-ulcer medications. A probiotic therapy can sometimes introduce bacteria into a susceptible small intestine. Alternatively, conditions associated with intestinal hypomotility or scarring, or after previous bowel surgery leading to blind loop syndrome or other causes of stagnation in the GI tract, permit bacteria to invade into the small intestine from the colon. These conditions permit an increase in bacterial counts to over 100,000 bacteria per milliliter, which then meets the definition of bacterial overgrowth. Small intestinal bacterial overgrowth exposes the complex sugars and other soluble carbohydrates in the small intestine to bacterial fermentation instead of allowing them to be hydrolyzed by enzymes and absorbed in the normally relatively sterile small intestine. The bacteria that are introduced into the small intestine can survive and thrive in the nutritionally rich environment. The condition leads to symptoms similar to those for other disorders of carbohydrate malabsorption. It can also destroy some vitamins, interfere with the absorption of short-chain fatty acids, and competes for sugars and other nutrients ordinarily absorbed in the small bowel. It is therefore a serious digestive disturbance which can be treated effectively, but only if it's diagnosed. Breath testing for SIBO with glucose, or sometimes lactulose, as a substrate is able to diagnose this condition, but it is sometimes a very difficult diagnosis to make, given the many variables involved in nutrient metabolism. Patients with diabetes should book a SIBO breath test utilizing lactulose as a substrate to avoid the high blood sugar peaks, but sometimes they will experience some diarrhea with this. Jejunal aspirate and culture is frequently mentioned as a gold standard, but it's really not perfect either, given that only a certain percentage of the bacteria that are aspirated from the small intestine can be cultured. According to some studies, only up to 50%. And of course, the test is uncomfortable, invasive, and expensive. Regarding the accuracy of SIBO breath testing, and I'll go over this again when we talk about interpretation, it is difficult to calculate the sensitivity and specificity since a really good gold standard is missing and since multiple different protocols have been used over time in previous research studies. When you distill all this together and combine hydrogen and methane measurements and compare to the gold standard of jejunal aspirate, as limited as it is, glucose SIBO testing may be 65 to 75% sensitive only, and about 85% specific on average. And lactulose SIBO testing is only 60 to 65% sensitive and only 50 to 70% specific. In other words, a lot of false positives are common with lactulose testing. Testing with glucose is less likely to overestimate the presence of SIBO, but can still generate false negatives. You can see that SIBO testing overall is far from perfect. One quick word about treatment. It should be conducted and monitored by a qualified provider and consists of sometimes repeated courses of non-absorbable antibiotics like rifaximin, followed by specific diets like low FODMAP diets, as well as supplements and probiotics. Sometimes specialized treatments are necessary, for example, for motility issues, even surgery to eliminate like blind loops that have previously been created by surgery or by some underlying disease would have to be eliminated. And even though probiotics theoretically introduce bacteria into the small intestine, they seem to be quite effective in the treatment of SIBO, at least in part and for some symptoms. There's a meta-analysis from 2017 on probiotic use that shows that a significantly higher rate of decontamination can be achieved in patients treated with probiotics compared to the non-probiotic group. Follow-up hydrogen breath testing was also significantly improved among probiotic users. The probiotics also produced a marked decrease in the abdominal pain, but did not reduce the daily stool frequency. Let's talk about lactose intolerance. The National Institutes of Diabetes, Digestive and Kidney Disease of the NIH at one point estimated that between 30 and 50 million Americans are lactose intolerant. Worldwide, it is one of the most common disorders and associated with many ethnic backgrounds, especially in people with Asian, West African, Arab, Jewish, Greek, and Italian descent. In Northern Europe, the prevalence is less than 5%. In Southern Europe, approximately 70%, and in Asia, it can reach up to 90% prevalence. Historically, the breath test replaced a blood test, which was based on the absence of an increase in blood glucose level following lactose ingestion. But this lactose blood test is not as reliable as the hydrogen breath test, since it produces a greater proportion of false negative and false positive tests. Now, importantly, lactose intolerance is not to be confused with a dairy allergy, which is an allergic reaction to milk protein. Lactose intolerance describes the partial or complete inability to metabolize milk sugar, lactose, which is present in all mammalian milk types, cow, sheep, goat, etc. It is reflective of a partial or complete lack of the enzyme lactase needed to split this sugar. As a result of not being able to break this sugar down and absorb it, the sugar molecules reach the colon and cause symptoms like bloating, gas, cramping, nausea, and loose stools, among others. This condition can be responsible for the discussed irritable bowel type symptoms, and it very often is part of the symptoms of celiac disease, but of course not the cause of celiac disease. It can be a transient or persistent symptom after bowel infections, after diarrheal illnesses, or antibiotic therapy. Lactose breath testing will diagnose this condition quite accurately, and the treatment consists of avoiding lactose-containing foods and supplementing the lactase enzyme with meals. Well, how accurate and sensitive is this test, this lactose breath test? When using hydrogen breath testing alone without methane determination, false negative results are reported in 5 to 18% of all lactose malabsorbers. Adding the methane testing reduces the number of false negatives and increases the sensitivity to over 90%. The specificity, so the risk of, indirectly, the risk of running into a false positive, is much better than a lot of the other breath tests. The specificity is over 95%. So the risk of false positives is quite low. Fructose malabsorption, also fairly common. Maybe 1 in 3 to 5 people, at least mildly. It is just as common in people with the diagnosis of irritable bowel syndrome as in the general population. And symptoms are quite similar to the other disorders that we discussed: abdominal pain, bloating, flatulence, and diarrhea. The symptoms are generally triggered by an intake of fructose-containing foods. Fructose malabsorption is not to be confused with hereditary fructose intolerance, which is a rare, potentially fatal inherited condition in which the liver enzymes that break up the fructose in the bloodstream are deficient. You'll never see this in an adult. Unfortunately, most afflicted patients would be in early childhood or infancy. Fructose is absorbed in the small intestine without help of any digestive enzymes. Even in healthy persons, however, only about 25 to 50 grams of fructose per sitting can be properly absorbed. This is the reason why some clinicians feel that fructose malabsorption is not really an issue, but there is a significant group of people whose capacity for absorption is actually significantly less. This is then defined as fructose malabsorption if symptoms and an abnormal breath test occur with consumption of 25 grams of fructose or less per sitting. Simultaneous ingestion of fructose and sorbitol seems to increase the malabsorption of fructose. Fructose that's not been adequately absorbed is fermented by colonic bacteria, producing hydrogen, methane, maybe hydrogen sulfide, and carbon dioxide, as well as short-chain fatty acids. This abnormal increase in the gas concentrations is detectable with the breath test with fructose as a substrate. There's also evidence that fructose malabsorption can cause decreased tryptophan, folic acid, and zinc levels in the blood. Restricting the dietary intake of free fructose and/or fructans, which are longer sugars containing fructose, may provide symptom relief in a high proportion of patients with such a functional gut disorder. One has to be careful with the results of the fructose breath test because a negative result does not completely rule out that a trial of fructose restriction may help that patient. In other words, the sensitivity is not over 90%. While a positive result is very specific that such a trial is useful because it demonstrates that the absorptive capacity for fructose in that individual is relatively low. Sucrose intolerance. Sucrose, also called saccharose, is a two-sugar chain, a disaccharide composed of glucose and fructose, which are bonded together. More familiar names are table sugar, beet sugar, cane sugar, literally the sugar that we eat every day. Sucrose intolerance involves a deficiency in the enzyme sucrase isomaltase, which is supposed to break the bond between the glucose and the fructose molecules. Once this enzyme splitting into single molecule sugars has happened in the small intestine, they can then be absorbed directly into the blood. A genetic form of the enzyme deficiency is common in the indigenous population of Canada and Alaska in up to 10%, but it is quite rare in European heritage, 0.1% only. Other, more common forms of the deficiency are acquired and are commonly associated with irritable bowel syndrome, aging, or small intestinal disease, so-called secondary sucrose intolerance. There are specific tests used to diagnose this. The most accurate test is the enzyme activity determination, which requires a biopsy of the small intestine. This is, of course, very accurate, but expensive and invasive and complicated. Another test which can aid in the diagnosis is the sucrose breath test, which is easy to perform and cheap, but slightly less sensitive and specific than the enzyme activity test. A deficiency of this enzyme may result in malabsorption of the sucrose, which can then lead to potentially serious symptoms, including episodes of hypoglycemia, low blood sugar. And as a result of that, the patient can experience dizziness, palpitations, anxiety, and even fainting. Since the sucrase isomaltase is also involved in the digestion of starches, some patients may not be able to absorb starches very well. It's important for those with this disorder to minimize sucrose consumption as much as possible. There are enzyme supplements available as a substitute, and these are really helpful in the therapy. And lastly, sorbitol sensitivity. Sorbitol is a sugar alcohol that is found in many types of fruits and vegetables. There, it serves as a precursor for sugar synthesis, and we consume it in small quantities with our food all the time. The substance belongs to the group of FODMAPs. Those are carbohydrates that are poorly absorbed by the body. Because it usually only occurs in small amounts in natural foods, our intestine is naturally not prepared to digest high quantities of sorbitol. Most sugar alcohols like sorbitol have a highly laxative effect, even for healthy people. With doses of 20 to 50 grams, the majority of people will develop diarrhea. However, if you experience digestive problems after consuming only a few grams, you might suffer from sorbitol sensitivity. The problem is actually much larger than meets the surface, given that sorbitol and other sugar alcohols are commonly used in the food industry, since they absorb water and prevent the dehydration of packaged foods. This is how products like packaged cakes stay fluffy and moist. The same ingredients also work as sugar replacement in diabetic foods and sugar-free or sugar-reduced foods, because they don't cause the blood sugar to rise as much. Hence, these products are popular with diabetics and Weight Watchers. Common natural foods that are containing sorbitol are apples, pears, apricots, plums, cherries, and dried fruit. And common processed foods containing significant amounts of sorbitol are chocolate, cream fillings, cough drops, chewing gum, packaged cakes, muffins, fruit candies, jams, and marmalades, as well as some medicines. Depending on the consumed dose, the symptoms of intolerance can range from minor flatulence to loose stools to severe diarrhea. The reason for this lies in the hygroscopic water-attracting effect of sugar alcohols. If large amounts of the undigested sugar alcohol reaches the colon, they cause an unpleasant sequence of events. The sorbitol draws the water from its environment, increases stool volume, leads to diarrhea, and then the intestinal bacteria ferment the unabsorbed sorbitol, often producing harmful metabolic products and digestive gases, which further irritate the GI tract. The symptoms are again quite similar to the other disorders of carbohydrate malabsorption, like lactose intolerance or SIBO. There are many studies that have shown that sorbitol-induced nonspecific abdominal symptoms and diarrhea are common in a significant number of adults, with diabetics slightly more commonly afflicted than non-diabetics. In some studies, up to 20 to 35% of adults will develop symptoms after ingestion of only 10 grams of sorbitol. These symptoms, when not properly diagnosed as sorbitol intake related, could lead to an extensive diagnostic workup and lifelong erroneous diagnosis of irritable bowel syndrome. A sorbitol breath test can diagnose this condition, and it is easy to do and is non-invasive. And there's generally a good correlation between the severity of symptoms and the levels of hydrogen or methane produced. One has to be careful, again, with proper interpretation. In some people, an intake of only 5 grams per day, the equivalent of 5 sugar-free candies or 4 or 5 sticks of sugar-free gum, can already lead to abnormalities with the positive test and symptoms. The intake of 10 grams per day has been shown to produce a positive test result in a significant number of people with symptoms in 20 to 35%. As mentioned, 20 grams would cause abnormalities in over 80% of people, so symptoms after 20 grams are probably the norm and not pathologic. Nobody generally tolerates such large amounts of sorbitol. Therefore, a positive test result on the breath test is only relevant if the consumption of sorbitol containing foods also lead to similar symptoms. The individual interpretation has to be done in the context of the patient's symptoms and the associated diet. Regardless of the test result, you should keep a diary of your diet and check if your symptoms disappear by avoiding sorbitol. If that is not the case, talk to your provider to make sure you receive the correct diagnosis and nothing else is missed. One possibility is that there is associated fructose malabsorption, since sorbitol in the intestine inhibits fructose uptake. The symptoms of sorbitol consumption can worsen if there is fructose malabsorption. In addition, to make it even more complicated, the body converts sorbitol to fructose. Therefore, fructose breath testing, in addition to sorbitol breath testing, is useful in some patients. So how do you do the breath test correctly? The more standardized the test is conducted in accordance to accepted protocols, the more reliable your results will be. The customer needs to have very accurate instructions and good information about the test. The customer needs to comply with the preparation guidelines that come with each test. This includes avoiding medications like antibiotics and probiotics for about 4 weeks. Other medications like motility medications need to be stopped at least 2 days before the test. There are specific dietary restrictions for the day before the test, the 24 to 12 hours before testing, like avoiding fiber supplements or high starch foods. And then the customer has to fast the 12 hours before the test. Smoking, sleeping, and exercising in the hour before or during the test will influence the gas levels and has to be avoided. Our customers receive, with their detailed instructions, a link to a video demonstrating the proper sample collection technique. The instructions also include proper labeling and packaging of the samples before mailing them to our lab. Upon receipt in the lab, the sample should be handled properly and processed promptly with a high-quality analyzer that is calibrated daily. Quick word about the portable hydrogen and methane analyzers that you may have seen advertised online to diagnose diet-induced disorders. They're not accurate and reliable enough to do the standardized breath tests we are talking about here. They are problematic and, in my mind, a waste of money, given that they are to be used often daily to test gas production after various foods. The problem is that there's no standardization of what results to expect after certain foods. There's no established normal value, and results will vary dramatically with orocecal transit time and types of diet from person to person. Multiple other factors interfere with the measurements and decrease the usefulness and validity of the results. I'm not sure what I would do with the results of such testing. It is probably better to rely on formal testing under stable conditions within a defined protocol and clinical information on food-induced symptoms. A word on hydrogen sulfide testing. You may have seen more and more literature on the role of hydrogen sulfide in IBD and also possibly irritable bowel syndrome. Sulfate-reducing bacteria can occur in the colon and in SIBO in the small intestine. And they consume hydrogen, which can explain some negative hydrogen breath tests. Hydrogen sulfide production is probably more common in diarrhea-predominant conditions. However, there are significant measurement and interpretation problems with using hydrogen sulfide breath tests. The normal levels in the literature vary dramatically from study to study. Measurements are in parts per billion, which is a factor 1,000 lower than the hydrogen and methane measurements. The thresholds for significant increases are not defined well, and in some disorders and some studies in SIBO, an actual decrease in the hydrogen sulfide levels after 75 to 90 minutes is observed, but a clear diagnostic criterion is not yet defined for that. The oral flora influences the measured levels of hydrogen sulfide in the exhaled air. So since research is showing contradictory and non-uniform results, more studies are needed, and I would say that these tests are not ready for widespread use yet. In addition, if you have SIBO, the abnormal bacterial population will rarely be exclusive hydrogen sulfide producing or methane producing or hydrogen producing. It is usually a mixed population, so usually the diagnosis will not rely exclusively on one type of gas that is produced in excess. And the treatment of patients with a hydrogen sulfide predominant SIBO case also is not different from hydrogen or methane predominant SIBO. It has not been shown that a low sulfur diet or avoiding sulfuric medications make any difference in the treatment. The interpretation of breath tests is somewhat tricky, given the potential for many interfering factors, most of which or some of which I've already mentioned. Various different test protocols have been used in the past, so the interpreting criteria have varied as well. Standardization of protocols is extremely important. The more standardized the conditions are before the test is done, the more likely you'll get a reliable result. Interpretation is certainly easy with classic patterns showing up, like the double peak in lactulose SIBO testing, which you rarely ever see. But it's not easy when the patterns are not as clear. Always take into account the specific symptoms and the history of the patient. A recently published North American consensus paper from 2017 on hydrogen and methane breath testing has characterized the cutoff values for abnormal breath testing, which is a useful reference for those unsure of how to interpret the diagnostic results. The guidelines state that a rise of hydrogen of 20 parts per million within 90 minutes during glucose or lactulose breath testing for SIBO should be considered a positive result, and the same increase within 3 hours for lactose intolerance, fructose, or sorbitol sensitivity. Also, a rise in methane levels by 10 ppm or more should be considered methane positive with the same time intervals. A combined increase for both gases by 15 ppm is also considered a positive test. The same report also defines consensus doses for glucose as 75 grams, lactulose 10 grams, lactose and fructose at 25 grams, respectively. Sometimes we see high baseline values. Elevated baseline values above 10 ppm for hydrogen can be observed in normal patients or in carbohydrate malabsorbers who did not fast properly or ate slowly digesting fiber-rich foods the day before the test. High baseline levels in hydrogen above 20 ppm can also sometimes be seen in patients who have small intestinal bacterial overgrowth. In those patients, these levels may increase further from the elevated baseline soon after the ingestion of a sugar such as lactose within the first half hour or so, and fall back near control levels towards the end of the test. Elevated methane levels are more rare, but can also be seen with bacterial overgrowth, and they may not change much during the test after the challenge dose of the sugar. In lactose breath testing, false positive breath tests are rare, and when they occur, they're usually caused by improperly preparing or performing the test. For example, allowing the subject to smoke, to sleep, or to exercise shortly before or during the test. Bacterial overgrowth can also produce a false positive breath test, but is usually preceded by an elevated fasting hydrogen level. Sleep during the sample collection or even intermittently raises hydrogen and methane levels falsely due to hypoventilation, inadequate gas and air turnover in the lung. Sleep also decreases the intestinal motility, which slows down the movement of the carbohydrates through the colon and allows a longer time for the accumulation of hydrogen. Tobacco smoke contains high levels of hydrogen. Therefore, smoking should be avoided, mentioned 1 hour before and during the entire time of the test and sample collection. The incidence of false negative results with the lactose breath test is well below that seen with the lactose blood test. False negative results on lactose breath testing are probably less than 10% when you use hydrogen and methane measurements. Administering a course of antibiotics in the weeks prior to breath testing may sterilize the colon, or at least decrease the count of the bacteria such that hydrogen production may be falsely decreased. Laxative and enemas can decrease the hydrogen and methane response in malabsorbers. The decrease may result from reducing the contact time for the carbohydrates in the colon, leading to a reduced time for fermentation. The reduced gas production may also result from a change in the concentration of the bacteria and a change in the environment, like increasing acidity of the colon with diarrhea. Inherent rapid transit of foods through the colon due to hypermotility with some disorders like hyperthyroidism will reduce the exposure time and decrease hydrogen production in the colon. I mentioned already colonic pH will affect hydrogen production. A decrease in stool pH from 7 to 5.5 will actually drop hydrogen generation to a quarter of the former rate. Thus, patients who've had severe diarrhea or a hyperacidic colon may inhibit the generation of hydrogen and cause the generation of negative tests, false negative tests. Most of the time, hydrogen and methane combined analysis will improve the sensitivity of testing in these situations. With regard to lactose intolerance, more recently a genetic test has been proposed, the CT13910 polymorphism. Several studies have demonstrated an excellent correlation between the breath test and this genetic test. And certainly in subjects with primary lactose intolerance, the genetic test provides an unambiguous result. But in secondary lactose intolerance, it has limited usefulness. Secondary causes of lactose intolerance may, of course, be suspected in subjects with a positive breath test and a negative genetic test. You shouldn't use this genetic test in children less than 12 years of age because of age-dependent changes in lactase activity. So overall, the recording of one or more of 4 symptoms, abdominal pain, bloating, flatulence, and diarrhea, either during a positive breath test and within 8 hours after a lactose challenge, is commonly considered the most reliable diagnostic method to demonstrate lactose intolerance in clinical practice. A word on interpretation in SIBO. Glucose testing, as I mentioned before, is better than the lactulose testing, but it may still not be able to diagnose distal ileal SIBO as well, given that glucose is mostly absorbed in the upper small intestine. This can be a source of the false negative tests seen with glucose testing. Lactulose testing, on the other hand, has a very high false positive rate and may only be able to accurately diagnose 50 to 70% of the patients with SIBO accurately. Rapid intestinal transit will look like SIBO, especially when using lactulose, which itself accelerates the intestinal transit. Not without reason, lactulose breath testing has been used in the past to measure orocecal transit time, with an increase in hydrogen and methane upon entry of the lactulose into the cecum. I already alluded to the problems in assessing the accuracy in SIBO testing, since there is no perfect gold standard and so many protocols. A lot of the research studies have used such variable protocols, so sensitivity and specificity calculations show a wide range. There was the 2009 Rome consensus paper, an expert working group that identified actually 11 cross-validation clinical trials that compared hydrogen breath testing without methane determination and the jejunal aspirate culture. From these studies, with admittedly different protocols and different methodologies, they calculated positive predictive values and negative predictive values and found that overall diagnostic accuracy for glucose breath testing was 71 and for lactulose breath testing 55. Based on these results, the expert working group concluded that the glucose breath test is the most accurate of the hydrogen breath test modalities for the diagnosis of SIBO. Now, the hope is obviously that adding methane to that testing increased these numbers. And looking at some newer studies, that is actually the case. Adding methane testing increased the sensitivity of the glucose breath testing to about 65 to 75% and specificity to about 85%, whereas lactulose SIBO testing was only about 60 to 65% sensitive and 50 to 70% specific, yielding a significantly higher false positive rate than with the glucose test. So the proof for SIBO really is in the treatment, right? If symptoms improve with treatment, for example, after eradication of the bacteria with antibiotics, even short term after a positive test, then SIBO was very likely responsible for the symptoms. How do you choose the right test? Well, that is not straightforward most of the time. Sometimes the customer has the impression that certain foods like dairy or fruit are triggers for symptoms, and that can make the choice much easier. A history of celiac disease or recent GI infections or antibiotic therapy can be a clue for lactose intolerance. Nausea is quite prominent and common in lactose intolerance, more so than in the other disorders. Constipation can actually also be a part of lactose intolerance, whereas in most other disorders of carbohydrate metabolism, these are more likely to be associated with diarrhea alone and not constipation. Other times, in fact, many times, the symptoms are vague or occur randomly, and there are very few clues in the medical history. SIBO can present in all kinds of ways, without specific food triggers. If there's a history of anti-ulcer or reflux medication, or bowel surgery, diverticulosis, or metabolic diseases that can affect the bowel motility, like hypothyroidism, then SIBO should be a consideration. Therefore, a good history by the provider is essential to choose the proper test. Sometimes several different tests are necessary, given that the symptoms of most of these disorders are very similar and non-specific, as I explained multiple times today. Why would you choose our lab to do these tests as opposed to other companies? Well, when the samples arrive at our lab, they get analyzed with our state-of-the-art analyzers, which also have the capability of correcting for room air contamination of the sample. We do this by simultaneously measuring the CO2 concentration in the sample and applying a correction factor to the measured hydrogen and methane values to normalize these to a standardized CO2 concentration. That adjusts for potential variations of gas concentrations during the sample collection. And this is necessary because during the breath cycle, the CO2 concentrations vary due to potential mixing with air in the trachea and deeper airways and with room air. We standardize our samples to alveolar air CO2 concentrations. Deep down in the lung, the normal concentration of CO2 is 5.5%, equivalent to 40 millimeters of mercury partial pressure at sea level. Our machines are calibrated with this value to account and correct for the improper sampling variations. And these analyzers are calibrated daily with these standardized gas mixtures. There's of course always the issue with faulty sample collection. But our clients for at-home testing get detailed instruction with the sample kit and an instructional video. The sample kit is very simple, so we try to minimize any errors. We use vacuum tubes, a closed system that prevents contamination with room air very well. We've seen some competitors at home sampling kits that utilize straws or syringes with regular tubes without vacuum and such, and are surprised to see how little is done there to avoid significant contamination of the samples. And as I mentioned, our tests are FDA approved. They fulfill a high standard. We have to follow the manufacturer's guidelines in performing the testing. We follow all regulatory guidelines in ordering and storage. And the samples have been shown to be stable for at least 2 weeks after collection, allowing for ample time to mail them back to us. As soon as the samples arrive at our lab, our technicians analyze them with an extraction system that is specific for the vacuum tubes we use. The results are then made available same day or next to the customer. We can collect samples in our office for customers that live close by, or we analyze samples that customers drop off or mail to our lab. The customer gets very detailed instructions, as I mentioned, and we try to be more affordable than other vendors through negotiating with the manufacturer and using very efficient workflows. Patients can also usually pay for the test with their HSA accounts. Lastly, all test results are reviewed by me, I'm board certified gastroenterologist, and I've dealt with breath test results for 25 years. So in summary, I hope I didn't exhaust everyone. Combined hydrogen and methane breath testing is able to assist in the diagnosis of a wide range of GI disorders, specifically involving carbohydrate metabolism and bacterial overgrowth. These underlying disorders are very common by themselves and can also be present as a part of other chronic GI disorders. Many patients with these disorders are erroneously labeled as having IBS and can certainly benefit from a more specific diagnosis. Identification of such a more specific disorder, like lactose intolerance or SIBO, can then lead to more effective therapy than the rather broad therapy for IBS. To get to accurate results with breath testing, you have to utilize a recognized and standardized protocol and accurate procedures. Thorough knowledge of the underlying physiology is important and helps to select the appropriate test, and is critical for the appropriate interpretation of the results, along with the knowledge of the specific patient's symptoms. At AllClear Healthcare, we believe we have a very advanced and accurate system that gives reliable results in short turnaround times. Our capacity and workflow allows us to offer this test at affordable prices and work with a variety of partners to bring such testing to everyone who needs it. Thank you very much. And I'm happy to answer questions.
Wonderful. Thank you, Dr. Hahn. That was an amazing presentation. There's just a few questions that I want to get to, and then I definitely like to ask Dr. Sedano to chime in with any comments. But I was going to ask you what that turnaround time was, because I did see on our website where we have that notated that results are back in 24 hours, which is unheard of. And also, I just want to I want to mention to everybody too, you can definitely find sample reports under the AllClear box on your Evexia account with the 5 different options, sample reports, and all that information. Pricing of this is really very competitive. $142 to $149 is the clinician price that we do offer. So really some better pricing and really fabulous turnaround time. There was one question here that I'd like to answer if anybody else wants to add anything. Just a few that we have in here. How do we get more therapeutic traction by doing this test versus just running a GI map and working on bacterial overgrowth issues? How does this test lead to more therapeutic specificity?
Quick word on the 24 hours. Saturday, Sunday probably doesn't count because our lab will not be open at that time. So if a test comes in on Friday, the result will probably be back on Monday, just to clarify that. But, with regard to GI map, I don't think that the test for the SIBO results for that are not really as good. And I think you have to specifically look at the breath testing. That consensus conference I mentioned from 2017, very reputable investigators were taking part in that expert panel. And they concluded that the breath testing is really the gold standard. And, think about it, the small intestinal aspirate, if you go down with an endoscope into the small bowel, you only reach a certain distance. So distal SIBO will not be captured by that. And there's really no sampling technique going from the colon up into the ileum without contaminating the sampling equipment. So the current gold standard in gastroenterology for SIBO is really the breath test. Does that answer your question?
Yeah, I think that's great. Dr. Sedano, do you have any comments that you want to share? That is really all the questions that have come in. Here's one more. Does the test give us specific information where the SIBO occurs?
No, it does not, because the gas production is happening in basically a black box. We don't know exactly which part of the small bowel this is happening. Indirectly, you could say if there's a very early rise in hydrogen or methane, for example, with the glucose breath test, you could presume that the proximal parts of the small intestine are likely colonized. There is, however, a study with radio-labeled glucose that actually shows that there's no good correlation with the location, because the scintigraphic, so the radioactive marker from the glucose, actually reached the distal small bowel quite quickly. So I think in general, I would say you cannot specify the location. If I see a really early rise, I might be inclined to say it's upper small intestine, especially if the history of the patient supports it. Let's say they're on anti-reflux medications or have had stomach surgery, which allows colonization of the proximal small bowel. Then that would be supportive evidence, along with an early rise in the gas, that you have proximal colonization. That's as far as I would go.
Thanks. Okay. Is methane SIBO better tested with the lactulose or glucose breath test?
With the glucose breath test, absolutely. Both. You have to combine both the hydrogen and methane measurements to get to the higher sensitivity and specificity. Even though both of them are not perfect and have their shortcomings, the methane increases the accuracy for both, and overall the glucose test is considered more sensitive and specific compared to the lactulose test, especially with regard to the specificity. Specificity I mentioned on the glucose breath test was about 85%, a range of like 78 to 92 or so, looking at those studies, whereas the specificity with lactulose was 50 to 70%, utilizing hydrogen and methane combined analysis.
Okay, let me just see if there's one more and then we can just move on. Do the results also include the proper treatment protocol for the test results?
We do not provide treatment recommendations. We're only a diagnostic testing company. Treatment should take into account the medical history. Like, for example, a SIBO patient who has a blind loop from previous bowel surgery requires completely different therapy than a patient who's been on long-term anti-reflux or ulcer medication, or has hypothyroidism, or various other, or has been recently on antibiotics, things like that. All those things will play a role in the discussion from the provider with the patient regarding treatment decisions.
Thank you. Dr. Sedano, do you have any comments or anything you want to add before we conclude the webinar and just walk through how to place the orders?
Yeah, sure do. One burning question, Doc, in your experience, Dr. Hahn, and it just has to do with follow-up testing after treatment. What's your opinion on that? And if so, when? How many weeks would you say, or months?
That's a very good question. I think part of that should be symptom driven. So if you have a patient that you've diagnosed with lactose intolerance and they swear they've avoided lactose and are taking lactase supplements with every meal and they continue to have symptoms, obviously that person needs to have other testing, not necessarily a repeat lactose intolerance test. SIBO testing is a good example that frequently will require repeat testing, especially if not all symptoms are improved. I alluded to fructose and sorbitol testing that frequently needs to be done in patients. They need both tests frequently. Repeat testing is probably not necessary if the treatment has been successful in alleviating most of the symptoms and the patient is happy. I think it should be more or less symptom driven.
Thank you, Dr. Hahn.
All right, Dr. Hahn, can you move to the next slide for me,
Yes,
please?
I can. Absolutely.
So I just want to remind everybody, we do have Ask the Doctor on the left-hand side from your Evexia portal. You can ask Dr. Sedano any questions on lab interpretation, general clinical conditions. He will reply back with a response within 24 hours. We have a free email consultation for any of that, or you can sign up for a live consultation. And you can find all that under the Ask the Doctor tab on the left-hand side of your portal. And next slide, please. So now that we have learned about AllClear's testing, I would like to review how to order the testing on the Evexia platform before concluding the webinar. First, you will need to log into your Evexia account and you will go to Order Labs, which is located in the left-hand column of the dashboard. Then you will select or create a patient or client to assign the test to. Then you will select specialty labs. You will find the AllClear testing at the bottom of the various specialty labs at the bottom. And you can find each of those 5 different options that are available. Add that test to the menu, and you can go ahead and check out. Those can be drop shipped directly to patients or clients. And finally, just complete that order and place your order. It's just that simple. And then last slide. We will wrap this up. For any questions or issues, you may contact Evexia Diagnostics by email at info@evexiadiagnostics.com or by phone 5 days a week at our extended hours, 8 a.m. to 8 p.m. Eastern Standard Time, 888-852-2723. Thank you, Dr. Hahn, Bill, and Dr. Sedano for this informative presentation. A recording of this webinar will be available by email in the next few days. Thank you again for joining us for this webinar event. Until next time, from everyone at Evexia Diagnostics and AllClear, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Good evening, everyone.
Thank you very much as well.
Thank you
Have a
very
good night.
much, and Wayne and team. Thank you.